I, as a surgeon, am taken care of in many ways. One, operating rooms, two, equipment, three, make sure that, there's a lot of indigent. I don't know how it is in Minnesota, but we have a lot of indigent care. And I think
Lots,
indigent care
lots,
is
lots.
all over this country. It's everywhere. So we can't work for free. I can't do, four open tibias and they all have no insurance and all I get is the call stipend.
Hey guys, welcome to another episode of Wellness at the Speed of Light podcast. We've already done a podcast before the podcast. We've got so much in common. Dr. Antebi and I just figured out that we kind of shared a journey that we didn't even know about. And so I'm just going to share that right now real quick, and then I'll let you take it from there, and then we'll just dive right into all the incredibly cool stuff that you're doing. And we'll talk about how cool orthopods are, in general. But it's the craziest thing. So when I was at Columbia University, we didn't have any high-speed trauma in the area. So they would farm us down to this place called Tampa General Hospital. It's a beautiful, it's beautiful down there. We covered all these hospitals, but I had 4 months of training under a guy named Roy Sanders, and we were just kicking around this, like our experience there. It's the craziest experience, and I can't believe it, because the reason I wanted Dr. Antebi on the show, first of all, like, as far as orthopedics, this guy is a monster. I mean, he does a ridiculous number of surgeries. You know how much I talk about, the more you do, the better you are. There's no question that complication rates and outcomes are better.
Sure. So similar to Stefano, he came down from Columbia. I was at a program in Michigan that was a community hospital. We didn't get a lot of high energy trauma, so our hospital farmed us down to Tampa General for 4 months. So I was down there for 4 months as well as a third-year resident. Orthopedic residency is 5 years. I was down there in my third year, and during the journey down there, I absolutely loved it. And our attending, who's kind of like world famous, his name is Roy Sanders. He was the chief and editor for the Orthopedic Trauma Journal, very established orthopedic trauma surgeon. He actually developed the Sanders classifications for calcaneus fractures. He developed a lot of hardware that orthopedic surgeons use all over the world to this day. So anyway, so when I was down there as a third year, he's like, I'd love to have you as my fellow here. So the nice thing is I didn't even need to apply. I already got the fellowship. Usually you apply for fellowship during your fourth year, towards the end of your fourth year. So when you're done with your 5 years, you do your fellowship. I was there as a third year. I got the fellowship offered to me. And when I was down there, it was just insane in the membrane. I mean, it was just
That's right.
absolutely crazy. The amount of traumas that we did down there, covering 2 hospitals and a couple of clinics, and it was just a phenomenal experience. So then when I came back as a fellow, like you were saying earlier, I mean, we were just it. A lot of times I would say, I'm on call with Roy.
Yeah.
He's on call at night and say, hey, I got a couple femurs, couple tibias, blah blah blah. He's like, why the fuck are you calling me? Just take care of it. I'm in Taiwan right now, giving a lecture.
You got it. You know what? We should do like a joint post on Roy Sanders. This
Yeah,
guy,
yeah.
a legend.
I'm still in touch with him.
Are
I
you?
think I think he loves my wife. I'm still, because my wife is very friendly, and every time we go on a
That's awesome.
every time we go to the OTA, or the Orthopedic Trauma
Yeah.
Association meeting or whatever meeting, he's there, and schmoozing with my wife. And last time I was just at the OTA in October, I think it was, and he was there. Deepa Squall was there. Remember Tommy Deepa Squall?
Yes.
And we're
Yes.
all hanging out, blah blah blah, and Roy and I were talking, and we're on a texting relationship. I just turned 55 in August, and he
Happy
actually
birthday.
did a video kind of post for me that Mindy, because I see you work out, I work out, he works out, he's always worked out, right? And he's in phenomenal shape, taking good care of himself still, and it was just a great time down there. Great. I was very fortunate to be trained by some of the best trauma orthopedic surgeons in the world.
Yeah, and I mean, listen, I can vouch for you. Those guys I mean, it was just amazing just to watch them, the way they move. They're so high speed. I mean, people are coming in, I shared my story of like that one night, the guy tried to cut off his leg. He couldn't quite get through his femur with the chainsaw. There's helicopters everywhere. I hear them oh my God. And I'm just thinking to myself, this night's never going to end. This is going to go like on for 3 days. There's just no way. And it was like early when I was doing my rotation down there, but they let us do so much as far as like, trauma as residents, especially the second time I went down as a fourth year resident. I got to do so much, trauma. And as I was saying, it really helped me for when I went to Louisville as doing all the spine trauma, really being, understanding the fast pace and the no sleeping, and you just go and go and go and just let that energize you.
I will say this, Stefano, that I think you and I are very similar in a sense. I mean, I don't know a lot about your practice, but I will tell you this, that when I was down there, not only did I learn to be a good orthopedic trauma surgeon, but I also learned the business of orthopedics, right? And the thing is that when we do our training, they teach us and we focus on how to be good technicians, how to
Right.
be good diagnosticians and be able to fix people. But they don't teach you in residency and fellowship, most fellowships, on the business side of things. And that's one of the things that I learned from like Dr. DePasquale,
Hmm.
who was also a workaholic and taught you how to dictate right, the coding, the billing, in addition to how the whole FOI was run, right? Just multiple surgeons, clinics, surgery centers,
Right.
hiring people. I mean, just the whole business of things. So when I finished my fellowship, I moved to California, and I could have went to like the big institutions, right? Like the UCLA,
Yeah.
Cedars, USCs of the world, but I didn't want to do that. I wanted to start my own practice and go through my own journey to build something. And that's what I've done. And I see you have done that as well.
No, listen, I love everything you said. Yes, I'm private practice through and through. I had zero interest in going to an academic center, despite how, depressing that is for my guys that train me in fellowship. They always want us to go to these big academic centers
Yes.
because they're like, "Oh my God, you just got this training from these world-class guys. You got to go here."
Yeah.
Luckily, this one of my partners who's actually retiring this year, amazing guy, Dr. Butterman, he does a lot of deformity. He, like speaks at all the meetings and stuff because he was such a researcher and such a renowned guy. They're like, well, I guess Butterman's at that practice, so we'll just bless it. Otherwise, they were like
Yeah.
never going to talk to me again. Those guys are
Right.
pretty. I mean, they're pretty dialed in. But anyway, Louisville, you said that learning the medicine, the business part of medicine, but just business in general, like the guys that, trained me, first of all, they ran a ridiculous operation down in Louisville. That thing was an absolute machine. We had 20 ORs sometimes going at the same time doing spines and everyone's switching and fellows here and residents. It was wild and just like really learning them. They taught us that. They just literally sat us down and taught us all these things. Here's how you build a practice. Here's what you do, blah, blah, blah. But then on top of that, they were also really amazing entrepreneurs. Like, for example, if you look at like Steve Glassman, who is like, one of my big mentors, him and another group, they owned all these Qdobas in the Southeast, like a lot of them, not three, lots of them, like a third of them or something in the Southeast. Dr. Randy Puno, who he just recently passed last year in 2025, is a wonderful man. He had a coffee company. Was like, his coffees were in all these hotel rooms, when you get those, the little, like not
Yeah.
Keurigs, but he had his own brand.
Yeah.
This is what I learned. John Johnson was Mr. Business. Like all he did was business. He had a private jet. He shared his private jet with Rick Pitino.
Wow.
John Johnson. So one time he's like, "You want to go up to New York? You're from there, right?" I said, "Yep." He's like, "All right, come to my private jet. We're leaving tomorrow." I just get on this thing. I'm flying private jet. We fly into a storm. The airport's literally closed, but they let this private jet land. We go in, we hang out in New York. Him and his wife do all the shopping stuff. And he's like, "I just meet him back. We get in the private jet and fly home." And I'm
Yeah.
like, you know what? This is a side to medicine I really like. And it was such a blessing, like to go there and see that because as you know, and again, this isn't like a lot of doctors are not what are going to watch like these episodes, but it's nice because people want to hear about us. But as you know, how many of your doctor friends, not necessarily in ortho, but generally know nothing about business, and it has led to them being in really difficult positions where they don't have any autonomy, they have no control, and all of a sudden all their banker friends, everyone else having a great time out on the golf course, autonomy, they manage their own time, and they're just told what to do all day because they don't know anything about business, so they're just trapped What do you think
Well,
about that?
several things have happened to put us where we are at today. One of them, because you and I are basically the same time
Yeah.
through out of training, was when I was a senior in my residency. The whole 80-hour work week
Yes.
came into play. All right, and the reason that happened is because I think of the story was a patient unfortunately passed away from a resident mistake, and then they were saying, "Oh,
Mm.
this resident in training was." Didn't get enough sleep, and this is why the mistake happened, et cetera, et cetera. So as a result of that, that kind of pendulum swung completely the other way. And now it's like, well, you can't work 200 hours a week. You can only work 80 hours a week, right? And when I was in my residency, if you were on call the night
Yep.
before, even if you slept in the entire night, come noon the next day, you got to go home. So as a fifth year orthopedic resident, last thing I wanted to do is go home because you're getting a knife every
Right.
day.
Of
I don't
course.
want to be home. I want to be cutting. I want to be learning. So we didn't take call our fifth year. We maybe one night a month or something like that. So that was it. But all the junior residents did. So when we did that, so because of that happened, it seems like the anatomy of the trainees that are coming out ever since that happened has changed, right? And this is why I think a lot of times, and I see this all the time. I mean, in 20 years of practice, seems like every year we new people coming out of training and they just take longer to do surgery. They seem less confident. It seems like they're less less capable, if you will. You know what I'm saying? And I see that a lot. I mean, there's still a lot of great surgeons out there, but it just seems like the people that are coming out today are not as proficient as when we were in training. That's number one. Number two is you and I are a dying breed, meaning private practice. Most people today, they don't want to come and hang a shingle and get a business license and start a practice. And it's a lot of work and a lot of risk. So a lot of people are just going into the managed cares of the world, like the
Mhm.
Kaisers. I don't know if you have anything like that in Minnesota where you are like an employed physician by a group where you just come in, you got
We
100
got huge.
patients.
We got huge. We got the U. We have big systems in North Dakota, and up north we have huge, huge systems. But private practice, especially in ortho, is alive and well. Like especially, like on the like joint side and sports, we have
Yeah.
two massive groups here, and they really help to restore some of the balance. I don't know how long it's going to last, but so far so
Yeah.
good. Keep going.
Yeah, yeah. So that's what I did. I mean, that's one of the reasons I came out, back in the
Yeah.
day, 20 years, exactly 20 years ago. And basically I came into a town where they desperately needed like new blood, an orthopedic surgeon. And at the time I was obviously trauma fellowship trained, but I did everything. I did total joints, I did carpal tunnels, I did whatever came through my door to be able to kind of establish a reputation, establish a practice. And then I was by myself for approximately 10 years until I started recruiting more people. I brought one of my
Oh.
co-residents from Michigan, and then I brought one of my co-classmates from medical school. He did his trauma fellowship at Vanderbilt, so he came. And then we just literally hired another guy 3 years ago, and we just hired another guy 2 weeks ago, and we're hiring another. I had a dinner last night. We're hiring another orthopedic trauma surgeon. So we're in expansion mode.
Love
We are
it.
growing, and we're going to try to keep this private practice thing alive and keep it going.
And you know what? There is ways to keep it going. And the thing about it, I just tell you, I tell this story. My book comes out this year, and I'm just frank. I just tell them how hard entrepreneurship is and how things can fall apart. So it was about, and I thought maybe it was the end because a lot of the private practices have been bought up, especially in spine. They really haven't. Neurosurgeons tend to go to bigger centers anyway because it's just easier. They go there, they command a pretty good living, but they lose their autonomy. That's a whole other, discussion. But anyway, so it was many years ago. Now I was going to think it's about 8 years ago. We were a small group. It was only three of us, and we got a letter, and basically we got dropped by Blue Cross Blue Shield. No
Oh,
explanation. We just got dropped,
wow.
as did a ton of other providers in the state of Minnesota. A ton.
So where do the patients go?
We didn't know what to do. So we had no idea what to do. They said, "Oh, they can, I just want to get into your stuff because you just like people just have to follow you too on social." It's like it's amazing. I told my personal assistant, I'm like, whatever that guy does, I'm going to start doing some of that. That's some cool, really cool stuff. But anyway, we were three surgeons. We get this letter. We just talked about it the other night at kind of a farewell party. And so I get this letter. I didn't know what to do, but I knew that at the time I was already like I was a really busy surgeon. So I could have gone to any system and gotten a great contract and gone there. And I said, oh, no way, because I live and breathe this practice, Midwest Spine and Brain. And so I basically we had to think of other options, and so I had to just like go on a quiet space, just take a little time off, and think like, how are we going to do this? Because it was Blue Cross was about 50% of our business at the time, right? So
Wow.
disastrous
Yeah.
for a private practice. So anyway, how are we going to do it? Eventually, I just came up with this theory, and this is not done in the state of Minnesota for spine groups. I said, I'm just going to go to these hospital systems and say, we'll do a provider service agreement with you. We'll come under your contracts, but we're not going to be employed doctors because we want to do it our way. And
Sure.
I was able to call, like literally walk into a CEO's office. He had no idea who I was, by the way. I had done just a little bit of surgery at his hospital. And I basically convinced him. I said, our group, it was only three of us at the time. I said, we do the most advanced reconstructions. We do all these like pseudarthroses and all these people that no one wants to operate on. You need us. And the group you're about to hire, they don't do any of this stuff. So I don't know how
Right.
you're going to take care of your patients. And so eventually we were able to get that deal. And then it ended up being like four other, we ended up, we have deals with four hospital systems, and now we're big. I mean, and so I've been able to grow it from three to now nine, and we're going to stay a steady state. We might be 10 just for a couple months as we've just brought on a new partner, just like you did,
Yeah.
who's just about to come on. We haven't even announced him. He's half adult and half peds, so he'll do peds
Yeah.
reconstruction, which is awesome. But anyway, regardless, it's just like we have to fight for this system because we as surgeons are going to do better when we are more involved at making the decisions on how to treat patients. We have more say on what implants we want to use. We have more say. Once you go into those systems, you lose a lot of that
Oh,
autonomy.
big time.
It's just the truth. I'm
It
not
is.
picking on systems. I'm not being mean for any administrator because a lot of the administrators do watch this show because we talk
Yeah.
about it.
Yeah.
I'm not picking on you. It is what it is. I mean, that's the reality. But I feel like we like our motto, right? Like our slogan is, free to put you first. And I don't just mean it about the patients. Yeah, it's good for, like patient facing because we really can make decisions that are more in line with what we really think patients need, but it's also free to put our doctors first. So thanks for being the beacon of private practice because we need more and more people like you, but they're afraid. They're
Yeah.
afraid. We could talk about the new generation for hours, and then we sound like a couple old men.
Our stories are very, very much aligned. So when I came into the area that I'm in, at the hospital, the major hospital back then was not a trauma center. So I
Mm,
started in 2005. It wasn't until 2007, 2008 that we became a trauma center. And at the time, the CEO that was there, and he's actually still there now, we became very, very aligned. And I told him, like, listen, you could start a trauma program here, but if you don't have a trauma orthopedic surgeon, you got nothing, right?
right.
You need orthopedic trauma in this hospital. So I said, listen, I'm fine doing it, you need to make sure that, I as a surgeon am taken care of in many ways. One, operating rooms, two, equipment, three, make sure that, there's a lot of indigent. I don't know how it is in Minnesota, but we have a lot of indigent care. And I think
Lots,
indigent care
lots,
is
lots.
all over this country. It's everywhere. So we can't work for free. I can't do, four open tibias and they all have no insurance and all I get is the call stipend. It's just not going to
It's
happen,
not going to work. It's right.
right?
It's not going to work. It
So,
just
so
doesn't
one of
work.
the so one of
Yeah.
the things that I did is I negotiated amazing contracts with you. I think you're at four hospitals. I'm at three hospitals,
Mm.
and two of them are level two trauma centers. And I'm very tight with all the CEOs, and they know what I bring to the table, like you brought to the table, and they say, listen, you know, if I'm in this hospital, nothing ever needs to get transferred anywhere else, right? It doesn't need to go to UCLA, doesn't need to go to Cedars, doesn't need to go to USC. I can pretty much handle as an orthopedic
Yes.
surgeon anything that comes in through this door. And if one of my partners are on call or whatever, or is another surgeon on call and he or she can't handle whatever that case that is, I will be your backup to take care of it. So everything stays in, but that's going to cost you. It's going to cost you a call stipend and it's going to cost a contract where if the patient is indigent, then we get a certain percentage of Medicare to take care of this patient. So that's what I've negotiated. And I've heard from a lot of surgeons from all parts of the country that are either working on RVU based type of thing because they're like an employment model and they don't necessarily get paid for call, or some surgeons get very minimal pay for call and
Right.
have to take care of whatever comes in. So there's a lot of different models out there. We have a big Kaiser system out here in California, and these are employment models. They work for an HMO. And these people, they're great surgeons, but they're not like the private practice model, right? I'm seeing like 100 patients in the clinic on my Wednesday. If you told a Kaiser patient is a doctor to see 100 patients, they're like, what? I
100 patients, so
more than
maybe,
30, I'm done,
and
right?
yeah, 100 patients maybe in 3 weeks.
Right, exactly right.
Yeah, it's a whole
Exactly
different
right.
ball
And,
game.
and not only that, but I think, people need to understand one thing. When you and I were in practice or in residency, the people and I know spine is a little bit more lucrative than doing total joints, but it doesn't matter. The numbers are the same. And the amount of collections or revenue that your trainees back in the day got for doing whatever procedure, right, is minuscule to what we get today. I mean, today we get peanuts. I mean, literally, like a total knee replacement back in 2005, my attendings were collecting $6,000, $7,000 per case. The joint replacement implants were like $15,000, right? Today, Medicare rate for a total knee is about $1,200.
Yep.
And then the implants are around $3,000 or $4,000. Everything is kind of dwindled down. So when you're in private practice, it's like it's a volume-based business also.
You said it right. Like with the indigent population, we have to be able to, we want to take care of everybody. And
Yes.
in spine, I can tell you, and I've talked about this openly. Unfortunately, a lot of that population in the old days, when it came to like private practices and stuff, private practices didn't want to deal with that because the reimbursements are horrible.
Yes.
It's like nothing. And when you're operating on the spine or the hip or whatever, I mean, the stakes are high, right?
And the
And
more complex patients because there's a lot more neglect because they didn't get the
super.
care they did, so a lot of them are more complicated. Do you take trauma call now? Do you take call
Yeah,
from
we
hospital?
take. Yeah, so we take. I don't. So the good news is that I only take backup calls sometimes because I run the practice. That's kind of like that. That's my, kind of torture.
Yeah.
But I really enjoy it. I mean, I love sitting down with administrators and COs and all these other people. But we cover a level one trauma center that is it is extremely busy. I mean, our census list is huge.
Yeah.
And between the neuro, yeah, because and the nice thing is there because we mostly the neurosurgeons cover there, and I'll back up for spine sometimes, but it is just it's constant. The head trauma
Yeah.
all day, and a lot of paralysis and
Yeah.
all kinds of stuff. So we cover that, and then the other centers are either smaller or and then there's a level three. Where we don't cover, we used to cover. It was easy. I mean, that's I mean, usually level three for spine is real easy because the bad stuff is going to bypass you. But
Yeah.
now that we cover that level line, and some of my partners actually, another hospital that we do elective stuff at, they do like some of the neurosurgeons will back up and do some neurosurgery call
Yeah.
there, and that's another crazy hospital system on the other side of town. But
Minnesota is historically a very quiet. You don't really hear about that state. It's been
yeah,
getting
well,
it's
not
been it's
well,
been
not in
get,
the
it's
last.
been getting a lot of bad,
Have you?
crap in the last few weeks. But
Uh,
when I think of Minnesota, I think bing 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 Mayo Clinic, right? That's what I
yes,
think,
yeah.
right? To me that's what Minnesota's all, and obviously the Minnesota Vikings, right? How did you end up in Minnesota
Oh no. Okay.
from
Well,
Kentucky?
I just did a post on this. People loved it. It was one of the posts that people. I basically I got a call. I'll just tell the story right now since we're just shooting it. I get a call from a headhunter. I was at Columbia. I was at PGY4. I got a call from a random headhunter. They're like, "Oh my God, we need another spine surgeon." I had put my name in the hat. We need a spine surgeon. Zero interest in leaving the Northeast. I had at the time zero, zero. And anyway, they called me from Minnesota, and I'm like, I don't want to go there. That sounds horrible. Minnesota, like I've
Yeah,
flown over it. I
yeah,
didn't know if there's
yeah,
anything in it.
yeah.
And so, I mean, I did know about the Vikings. I'll give you that. But anyway, so I got a call. And then finally, my wife is like, why don't you just check it out? Like, we had gone through 9/11 and all these other things. She's like, we should look at other places. We don't have to be stuck here in the megalopolis, right? So I go check it out. It seems okay. I hang out with this administrator. And his name was Greg. He drives me around and he's telling me, "Oh my God, this guy that we just hired, he's a military guy. You guys are going to be incredible partners, the two of you." And I said, "That's great. When do I get to meet him?" "Oh, he's coming to dinner tomorrow night. Everyone's excited." The other two, there were two other partners at the time, and they had hired a third, and I was supposed to be number four. So I'm sitting at this administrative, like luncheon with them, and they're telling me the practice, the numbers, and what I don't even know what I'm looking at because I was so like uneducated as far as like what. But and I
The
wasn't, to
business.
be honest with you, I went there not interested. I
Yeah.
wasn't even interested. I was interested. It seemed like a great practice, but it's in Minnesota. But it
Yeah.
seemed cool, and I started warming up after a day. Anyway, I'm there. The guy takes a phone call. And he's like, "Oh, I'm sorry to hear that," or whatever. And it just and all of a sudden, like literally all of the color went out of this guy's face. And it was like 5 minutes in because he had been talking and he seemed like completely normal. And then he's like, "Oh my God, I'm so sorry to hear that." And I said, "Well, what's going on?" So he walks out, he's on the phone, it's all like weird. He comes back in, he's like, "I don't know how to tell you this.
The guy died.
The guy died the night that I flew in.
Wow. One of the people that you
The
were
guy
supposed to.
they had just hired,
Yeah. Oh
he
my Lord.
died." So he got into like this altercation in a bar.
Wow.
He's a military guy, like a military guy. Some of them are, like we're kind of, they could be
Fine
like
surgeon.
a spine surgeon, military
After
guy, had
all the
just finished
training, all the years of
all that.
torture.
He gets into an altercation and walks across the highway and gets killed
Oh
on
my
the
Lord.
highway, gets run over. And people had called into the police, say there's some guy staggering along the highway, walking back and forth. It's
Wow.
crazy. This happened the night I flew in. And so anyway,
So
it
now
was
your
weird.
value just doubled.
Oh my God. There you go. But anyway, it's kind of weird. So I go to this dinner and I hadn't met the partners yet. And Dr. Reeser, who's since passed, he was the founder of this group like 37 years ago. And it's very awkward. And they still wanted to do the dinner. They said, "You came all the way from, New York. We might as well do the dinner." This is even before I'd done my fellowship. So I sit down and he just looks at me. He didn't know what to say. He's all red and he looks at me. He's like, "I guess we really need you now." And
So
that's
you
it.
so you're in your last year of training in Columbia. You weren't even
I
done with your
wasn't even,
you
no,
didn't even start your fellowship
I
yet.
took the job, before
Wow.
fellowship because I don't know if you looked at any jobs in the Northeast, it's a little harder to get like really good jobs, especially in the New York City area, Connecticut, like the really coveted areas. Because what you don't want to do is you don't want to go take a job where you're getting paid what average, normal people would think is a lot of money. But if you live in New York and you're doing that, you're living literally like in like people's like a bathroom, like it's tiny.
No, no, but that's the same reason what you did. You moved to a state that really, really needed you, right? You
Yes,
weren't moving to like New York where there's like, 400 other spine surgeons
correct.
you need to compete with. And this is why when I moved to California, I moved to a town called Lancaster. It's they call it the armpit of LA County, literally. In my practice there now, we are the only group. Imagine if you were the only group in town
Be
that
crazy.
covered spine. We are the only group.
That's
We built up this
insane.
insane group that we're the only group that covers the two hospitals. There is nobody else. We have no competition. And you would think that with all the residents that are coming out of training, UCLA, Cedars, there's a bunch of
Right.
residents
Yep.
down here that somebody would come up and like plant seeds and move up to our area. But because we are kind of like a less desirable place to live in practice, we have no competition. But I didn't know this 20 years ago. I just like put my, started practice there and it just exploded, it just built something. And
Love
the
it.
other thing I will say is that most surgeons, whether you're a spine surgeon or an orthopedic neurosurgeon or whatever, most people who end up going to work at whatever practice that they're going to, it's almost like divorce, right? It's like, 60, 70% of the time, 80% of the time, you go in, you're practicing and you just don't like something. Either it's the town, the
Yep.
people you live with, the hospitals you're at, the place gets bought out, and then 3, 4 years later, 5 years later, you're moving to another job, right?
Yep.
And then you got to
Huge.
start your reputation all over again. We're not ER docs, we're not anesthesia. We need to like earn our reputation
Correct.
and earn our business as surgeons, right? Your name is like gold when you have that reputation that's up there. So fortunately, I've been there for 20 years. It sounds like you've been in the
Same.
same place for
Exactly.
20
I'm
years,
20 years.
right?
Exactly
And
20
20
years.
years of Syncropy, it's like boom. It's like every patient you take care of is like your walking billboard.
Yes.
You don't need to advertise.
It's funny. I always say that people ask me, they're like, oh, how I was like, I used to, when I started, I used to, call on, primary care docs and all these other people. I,
I did the same thing.
I just put clinics on and they're full. And they
Yeah,
just
I
were
mean,
like, I
yeah,
was like,
it's
oh,
exactly right. So I did exactly the same thing. When I first moved
yeah.
into town, I'm white, I'm Jewish, I'm a DO, and I'm surrounded by a bunch of like ethnic doctors, the Indians, Sri Lankans, Asians, and I put a suit on, a tie, and I literally back then there was no iPhone, right? We're talking 2005. Yeah, you're lucky if you had your BlackBerry, right? There was no
Yep, yep,
Google
yep.
or anything, no Google. So back then, I literally went to the yellow pages. I'm like, I want to see every damn doctor in this town. And I went to every doctor with my business card. This is
Yep.
who I am, and please send me business. That was like the first 2 years of my
That was
practice.
my life, man, for
Yeah,
years at the
yeah, just the
beginning. My life,
hustle, the hustle.
lunches and stuff. It's funny
Yes.
because my first ever like little talk event that I did was at some place called the Elk River Rotary Club. If you knew Minnesota, you would know Elk River is like it's up northwest. It's kind of middle of nowhere. It's actually grown now, but it was like a tiny little town. And I'm at their Rotary Club. I still have the little mug with the like Elk River Rotary Club, and I
Yeah.
remember, and I was so excited. I gave this whole thing minimally invasive spine, the new frontier,
Yeah.
like, paraspinal muscle splitting and all the stuff. And I
Yeah.
was so excited. And I remember, and I know you know this feeling because we kind of, with such a similar story. And so like a good friend of mine, he's a rep. He still makes fun of me to this day because he just remembers it was like I was maybe like, I don't know, 4 or 5 months into my career and I was doing all this stuff. And one day I had four whole new patients on my schedule. And I was so pumped. I was like, I just saw four patients today. It's coming together,
Amazing,
man.
isn't it?
The world is conspiring for me. It's all coming together. Now, like I'll start my clinic at 9 a.m. and I've seen four new patients and it's 9:45. It's
Yeah.
like it's
Exactly.
crazy. And it's
Yeah.
all reputation and what you do. And you know, uh, it's just this is like real important for people to also understand because I want to this conversation, like I said, they just go wherever they go. But one of the things that is amazing about private practice, and I really think is being lost with the current models right now, is our ability to build reputations and to build these giant practices. Now, don't get me wrong, there are people in academia that have giant practices, but for the most part, they're not high volume surgeons. They're just not. That's just not the way it works. In
The
spine, the
system doesn't
difference.
allow for it.
I mean, one year, like I know how many surgeries you do. I've seen it, I've kind of seen it posted on, on this thing. It's great. You'd have to do that. And I want to come to you. Like if something happens to me, I'm calling you. I'm like, I'm going
Yeah.
over there, right? If I'm in your area. But regardless, it's like, one year I did almost 800 spine surgeries.
Wow.
Right. And it was just crazy. It was like, I forgot the number, 760 something or whatever. I since now that I'm doing more media stuff and traveling, it's a little bit less. But anyway, it's like when you said that our breed is going away, this is what concerns me. What concerns me is that these guys they're not building this massive, background of experience. Like when I tell my patients, like I'm going to do an ACDF on them, I always say, you know what? I was like, I do everything in spine, but I've done, way over 2,000 ACDFs and this many disc replacements and 4,000 like lumbar fusions and whatever. All this stuff that counts for something. It does make a difference because you need those guys to be able to handle like the stuff that people don't want to do. And here's my contention: this new group that's coming out. Not only are they not coming out, and they don't even want to be high volume surgeons, first of all, because it's not going to mess, it's not good for their lifestyle, but they also don't want to take on the really challenging cases. And so when you're gone, and our generation is gone and moved on to the next thing and hopefully good stuff, right? We're either
Right.
golfing or hopefully
Right.
I'm on like having my hosting a show, right? The next the male version of Oprah or something like that, but whatever. Like when we're gone, like on it, we talk about this all the time, and not just even with like my competitors in town, like when we're in the, like when we're all friends, in the doctor's lounge, we're like, honestly, who's going to do this stuff? Because if
Yeah.
they're going to do the primary stuff and they don't know how to fix what happens afterwards, like where are we going now? Luck, maybe we'll have the robots doing all of it, and so it will be irrelevant. I don't know. What do you say to that? I mean, how important is it to have
I think
guys that just
I
do
think from yeah,
thousands of
from what
surgeries?
from what we do, I don't see robot doing, I mean, we have like robotic
Yes,
knee
yeah, but they're
replacements and
not.
hip
You're doing it.
replacements,
You're
but
still doing it.
yeah,
Yeah.
it'll definitely be beyond, my lifetime
Beyond
is
our career, beyond our
yeah,
careers.
exactly right,
Yeah.
exactly right. But I definitely agree. Listen, I've been around like you have 20 years in practice, right? And you see what's out there. And every time we get, a new doctor that comes into our hospital that is either taking call or not taking call and doing cases,
No.
like there's nothing worse for me that for me to have to follow another doctor on the lineup
Yes.
with surgery, right? Like, for example, this morning, right? I had a guy that had bilateral bad wrist fractures, and they told me that I wouldn't be able to start until 1 o'clock today. That was yesterday. They told me that. And then they called me back and it said, uh, we're going to let you start at 7:30 because there's somebody following you like at 9 o'clock. And the reason why they did that is because they know I'm very highly efficient in the
Yes.
operating room. Like there's no like missed moves here, right? Like everything is calculated, right? So when you're going
100%.
into the operating room, you already know exactly what you're doing, how you're going to do it, and what you're going to fix, and there's no messing around. So literally in 1 hour, I fixed this guy, 29-minute tourniquet time and 26-minute tourniquet time, and I'm done. And then the next surgeon can move on. But when I come to the hospital and there's another surgeon in front of me, and I'm supposed to start at 9 o'clock, now I'm not starting till 11
Right.
because we're dilly-dallying in the operating room, right? And we see that all the time. And the staff, I hear it from the staff. It's not like sometimes I wish I was like a fly on the wall
Yes.
in operating rooms to see what are these guys doing in the operating room. Are they like dissecting cells? What is taking
I love
so
it.
long? What is taking so long for this hip fracture, which normal, I mean, hip fracture is like the most common
So
surgery
basic.
a
So
surgeon does.
basic. Yes.
Right? That's like a second, third year resident case, a hemiarthroplasty or an intertroch. I mean, those things should take you less than 30 minutes. I mean, I'm doing them like less than 15, but less than 30 minutes. So when I hear a doctor takes an hour and 15, hour and a half, that's a long time. And that's just his cutting time. It doesn't include you getting the patient in the room,
Right.
anesthesia, positioning. That's his time, an hour and a half. And I'm like, that's way too long. So what is happening? What is the reason? And then sometimes I give them the benefit of the doubt, right? They just came out of training, they're a
Yeah.
little, they want to make sure everything's perfect, et cetera, et cetera. But now you're 4 or 5 years in practice and you're still taking an hour and a half.
Bingo.
So what's going on?
No, yeah, I agree. I think what a couple of things are going on is that people are a little bit more focused on lifestyle, this and that. There's a lot of fear. People don't want to do the hard stuff because you know that when you're doing the hard stuff, there's times where it's going to get even harder, right? And it's going to complicate. And spine is a little bit, I mean, it's just it might be a little bit different. So I just think there's many reasons, but I can tell you, like in our community, the younger guys don't want to take on anything. Like some of the stuff that they refer me directly, I'm like, you referred this? This is bread and butter. This is not like
Yeah, it's
you
not
need
even
like
difficult. Yeah,
Sinicropi to like do
yeah,
some huge revision. I'm like, this is like, oh, because there's more,
yeah,
there's a lot of compression on the spinal cord. I'm like, that's what we learned. That's what we do. It's like, oh, it's too compressed. It's too dangerous. I'm like, it's ACDF, like, 101. And I love what you said. And it's funny how much like we think alike and like the sayings it's the what do you do I don't know what you're doing in there. So for example, like my ACDF, a one level ACDF in my hands, because I've done thousands of them, in
sure.
somebody like you, 35 minutes an
Yeah,
ACDF, skin to
yeah,
skin, it's done,
yeah,
no
yeah,
problem, get the nerve.
yeah.
And there's
And
nothing.
people take 2.5 hours.
Some people take 4 hours to do a one level ACDF, and you're exactly right. Are they actually doing cellular dissection? Are you splitting atoms in there? Is this like a nuclear
Yeah,
experiment, or
but
are we doing surgery?
here's the other thing. Here's the other thing. Like, some viewers, right, may watch this podcast and say, 30 minutes. You're doing it too fast. You're going to make a mistake. You're going to cut something. I want the doctor who is taking his time and is being more meticulous, right? But here's the flip side to that coin, right? And you know this as well as I do.
Yeah, I
In my opinion, every surgery that we do, even though we sterilize the skin
right.
and we do everything possible to minimize infection, every surgery we do gets inoculated with bacteria from the lights, from our hair,
Every
from our
single
mat.
every single surgery.
That's number
No
one.
way. Absolutely.
Number two is, in my opinion, right? The longer you take to do a surgery, the more inoculation happens, number
Yes.
one. Number two, The longer you do a surgery, a little bit more bleeding, more anesthesia, more retraction on the soft tissue. So you wake up and you're like, oh my gosh, I'm so sore, my neck or your head, whatever it is that you're doing, it's just more trauma and more exposure to
100%.
the patient. So that leads to more higher risk of complications, infection. When you're doing ACDF, it's what? The vagus nerve, it's the trachea, it's all this stuff you worry about as a spine surgeon. So the quicker you're in and out, doing a good job, the better it is for the patient.
Yeah, you know what? I'll tell you a story. This is true. This is like true story. I haven't talked about this before. And I actually, she's great. This nurse, I love her. I'm not even going to say her name, but she's awesome. She loves me. When we started at that hospital, I told you about we lost our, we lost our contract. We got it back. It's funny, we got it back. It was all a financial thing. They dropped us down in what they wanted to pay us as far as reimbursement. It's fine. It wasn't that much. It was like 10%. So eventually we got the contract back, and it was only like about a year of negotiating this and that. But anyway, this nurse, they came on, really sweet lady. Like I said, I know her very well now. When I came on board at this new hospital, um, I had a lot of experience already because this is like 8 years ago. So I'm in 12 years into practice. So I had, like my techniques are the techniques. And I always say same way every time. That's like I say same way every time. The
Just like
steps are
we
the
did last
steps.
time. Just like we
Same way.
did last time.
Yeah, but some of the, you hear it all the time. You're like, oh,
Yeah.
surgeon so and so, every time they do the surgery, they do it different. I'm like, why? This is
Yeah.
standard. That makes it way longer and more stressful and whatever. But anyway, this lady, I was really upset with her at the beginning. So I came and I did a bunch of cases. So it was like maybe the third or fourth time I was there, I had like 7 or 8 spine cases. And first of all, no one, like, they don't do like that. They don't even know what that is. So I had to lobby for that and talk to anesthesia. Trust, I'm safe. It's fine. Don't worry about it. So they're like, okay, that's fine. You can do it. Everybody was on pins and needles. So I do all these surgeries. And then this lady, she starts a rumor around the hospital that I'm not finishing my cases because it's not possible. She's telling everyone, she's like, it is not possible to do surgery at that speed. Meanwhile, everyone's fine. There's no issue. Everyone's fine. Yeah, like the people are great. Surgeries are going great for my thing. It's like just business as usual. Now, after being there for a long time, many years, it has so flipped on its head. Every time I'm in there, like the scrub techs, and then they're like, they'll be like, I wish people were as efficient as you. Like they don't want to work with some of the other surgeons. In our group, we have a lot of efficient surgeons, but there's other people, they are like, they even the scrub techs don't even want to be in there. It's like anxiety provoking because even they're like, what are you do? Like, what
Right.
steps
Well,
are you doing?
when they work with a surgeon like you, and then the next, the rest of the day they're working with another spine guy who's taking 3 hours, what's the issue, right? I mean, so they see the difference, right? They
And I
see
don't
you
know. I
and
don't
they
know.
see
You
the
don't know.
other
We're like, I
surgeon.
don't know.
So like when I'm on, they call it Antebi Tuesday at the hospital. So when I'm there on Antebi Tuesday, like, this week I did like 8 or 9 cases, right? And I usually get 2 rooms, 2 teams, 2 anesthesias, the whole thing. And I always tell, the staff, I go, the longest part of my surgery is not the surgery. It's getting the patient in the room, getting
Correct.
the physician, getting him prepped, doing the anesthesia. Once that patient is prepped, it's, 30 minutes to do the ACDF, but it takes 30 minutes to get the patient from
Right.
pre-op to the room, on the table, anesthesia. That's like 45 minutes. So typically when I'm doing like my traumas and my total joints, I do a lot of total joints. By the time I make incision on the first patient, I already saw the second patient. They're already marked, ready to go. So I said, okay, go back with the next case. So they're already going back as I'm cutting on and doing surgery on the first patient. By the time I'm done, that next patient is ready to go, right? It's ready, prepped, ready to go.
Absolutely.
So I'll do the second surgery, and by the time I'm done with the second surgery, they haven't even like they're just bringing in that third patient because they didn't have enough time to, the cleaning and the getting the stuff open again and getting the patient in the room. So, so when you're efficient like that, the hospital recognizes that, right?
Yes.
And they will do everything they can for you to make sure that you remain efficient because you, as a spine surgeon, bring a lot of money to the hospital, right? It's a very lucrative
Lots for
situation
them.
for the hospital, right?
Yes.
So they want to make sure that you are taken care of, right? But if you're taking 4 hours to do an ACDF, they're not going to bend over backwards for you.
No, absolutely right. I have days. So I started about 12 years, maybe 10 years ago at one hospital that we're no longer at. I actually approached anesthesia and I approached everybody. And the problem with spine is that some of the cases, like fusions, even though an ACDF might take a short period of time, sometimes opening the room because there's so many trays can be really time consuming. So
Yes.
at some point, about 10 years ago, I got to the point where even having two rooms was not efficient enough for me because I would finish my first and second case. And then I'm just hanging out in the doctor's lounge doing random stuff, being antsy because I just want to operate, because I want to be in
Sure.
a flow state, because flow state is
Yes.
really important in how
Yes.
successful we are. I do not like to sit around. I want to get into an absolute zone. Like when you're in the middle of a championship basketball game, like, yeah, sometimes you take breaks and you're going to sit on the sideline, but you don't go home and then come back. You
Right.
lost all your momentum. So I'm a momentum guy. So I got to the point and I approached this hospital. It was a huge deal. And I just said, listen, I whatever. They're like, oh, we're going to watch you. So they gave me the three rooms and it worked really well. So I've been doing that for the last 10 years. So when we did some of these more recent deals, I went to them. I said, listen, I know that you're not used to this and you've never seen it before, but I need three rooms in order to be efficient, especially when I'm doing cases that are taking that time. Now, yes, on days I'm doing scolies and AP fusions, that's
Longer
different. I don't
cases. Yeah.
need that because then
Yeah.
we just stagger them in two
Sure.
rooms. But
Yeah.
I have two, so two times a month, I'll do the 3 room days, and I'll try to always shoot for like 8 to 10 cases on those days. It's very efficient. The patients like it. They get through. We throughput them, and then when you're doing a 30-minute operation or a 35-minute, minimally invasive decompression through a little tiny portal, those patients, when they wake up, it's like they didn't even have an operation.
Yeah.
Okay,
Because
you keep them open for four
yeah.
hours,
Yeah.
they
Yeah.
screaming in pain. And I get it. Some of the scolies and stuff that just goes along with it. But everybody knows, like if you do a posterior cervical surgery, the number one predictor of how much pain they're going to have, like that's controllable, is time of retraction.
There you go.
That's just the way, that's what it is. It's like time. So a 6 hour posterior cervical, the patient's going to be horrible pain and if you do it in 45 minutes and you're just doing a posterior fusion, putting some lateral mass screws, and your time from cut to close is 45 minutes, that's a whole different, it's a completely different experience for the patient. The hospital loves it because they make more for that episode. It's just like everybody wins. And so it's just interesting. I'm sure you've heard like the same stuff. People are probably like, how the hell does he do it in that amount of time? How is that possible?
Yeah, I hear that all the time. And not only that, but this is, obviously I started this about almost 14 years ago. And I'm sure you do the same thing with, basically outpatient total joint replacements.
Yeah.
So we have our surgery center. You can get your knee replaced, your hip replaced, and you're going home the same day. When I was in my residency, I remember rounding on these people, right? A total knee would stay in the hospital for 3 days, 4 days.
Or get admitted the night before for a workup.
Yeah,
Remember
yeah,
those
yeah,
days?
yeah,
We were doing
exactly.
that
Yeah,
at
we did
Columbia. We
that
would
too.
admit them the night
Absolutely.
before for
Yeah. So
spine.
today it's
Yeah.
completely, we've become so efficient with the
Yep.
advent of blocks and periarticular
Yep.
injections
Yep.
and our quickness with the surgery and smaller
Yep.
incisions. Things have gotten a lot better, but you still have to be efficient at what you do, you know? So I follow you as well as you follow me. And like I said, we look like, brothers from the
Brothers
same
from another mother.
mother. And one of the things that I wanted to talk to you about, which is very important to me, and I'm sure it's important to you, is just our vitality, right? Like
100%.
you,
That was
you,
literally my next thing. It's funny. I didn't know we were gonna. I pride myself on my show not going down like these big rabbit holes of our own personal practice. Because after a while, people are like, "Okay, you guys are doing a lot of surgery. You're really fast. Great.
yeah,
That's good
yeah,
for you. I'm glad you guys
yeah,
are talking shop and having a great,
yeah,
and having a great
yeah,
time, like making
yeah,
fun of everybody else.
yeah.
But let's yeah,
But
let's talk vitality. This is my thing. This is my jam. Go ahead.
how old are you, by the way?
I am 52, going on 53.
All right, so I'm 55, so a couple of years on you. But the point of bringing this in is when a patient goes to see their internist or whatever, and they talk about diabetes and high blood pressure and obesity, and they're like not in great shape. It's kind of like it's hard to instill that in a patient when you're not a great
Yes.
role model, right? But when you walk into a room and you're physically fit, you're taking care of yourself, and you tell your patients to lose weight and start working out and do all the things that they need to do to better the quality of their life and longevity, it's important that you play the part in doing so, right?
Walk the walk.
And I commend you obviously for doing that, because obviously you look like you're in fantastic shape
You
at
as well.
53 years old. And this is what I pride myself in. I pride myself in, I don't feel bad. I don't feel ashamed. And a lot of my patients, they know I don't bullshit. When I go in there, I'm not there to like coddle you and hold your hand, right? I'm here to basically tell you what it is, because I have, as doctors, we have a huge influence on our patients, right?
Massive.
Some of them may like it and some of them may don't. But I guarantee you, when they leave that room, when they leave your office, they're thinking about the shit that you said, you know? And when I have a patient that is, morbidly obese or obese, and they come in and they have two bad hips or two bad knees, I say, listen, I am more than happy to help you, but you have to help yourself first. And I don't, there's a lot of surgeons out there that will not operate on these certain BMIs. And I'm not one of them,
Me
because
neither. I operate on massive
I
people.
know how hard it is. But
Yes.
what I need to see is I need to see a change. So if you walked in here at 5'2" and 320 pounds, right? We're going to talk about your surgery, but we're going to give it a couple of months, not a couple of years, but a couple of months. But I want to see you at 300 in a month, right? I want to see that 20-pound weight loss. I want to see that you're in enough pain to change the way that you eat and the way that you don't exercise, and your lifestyle. Because if I replace your knees at 5'2",
No.
330 pounds, these replacements are going to fail in 5 years. We know that. Studies show that. So, and you're only 60 years old or 55 years old. And we don't know what your longevity is going to be being morbidly obese. You may die at 65 and we don't need to worry about it, right? But if you're going to live long, and if you intend to live long, you need to lose the weight. You need to take care of yourself. And the other thing is, even for my osteoporotic patients, I mentioned
Mm.
earlier, the most common surgery I do as an orthopedic surgeon are hip fractures, right? And 9 out of 10 times they're women. Two reasons. One, because they live longer, and two, because osteopenia, estrogen, osteoporosis, and everything else. I don't even order what's it called, the
The
bone
DEXA
test,
scan?
the DEXA scan. I don't even order it. We are orthopedic. You are an orthopedic surgeon. You put screws in people, and I tell people, I'm like, putting a screw in my back and putting a screw in your back, being
Yep.
70 years old, is like the difference between a 2x4 and drywall. I don't need a DEXA scan to tell me that. I know you have osteoporosis, and
Right.
I know that if you fall, you're going to break your hip. 40 years ago, same fall, same mechanism, probably wouldn't break your hip. So I tell these people, I go, walking around the block and walking your dog, that's great, but that's not exercise. You need to lift weights. You need resistance exercises, right? What do you
Yeah,
have to say?
no, honestly, I mean, if you think about it, I mean, you just brought up like the whole osteoporosis thing. A lot of it, yes, is the estrogen stuff. And unfortunately, women got the shaft with that very poor study from 2000 with the estrogen
Yes,
replacement and just the heart disease and all that. And I'm glad that now that's turning around because we're
yes,
seeing a lot because we need to do, and we do it. I mean, I do so much integrative health now, as well. But that's neither here nor there. The biggest thing that really affects the spine surgery, in addition to all the diseases that you mentioned, but like in that category of osteoporosis, is sarcopenia. These people have literally no muscle on them, and you can see it if you look at a lumbar MRI scan. You can see the fatty replacement of muscle. In some people, it's literally crazy. So we call them, you know what I call them when we're doing operating? Petri dishes.
yeah,
I'm like, it's not even vascular. It's just
yeah,
fat. And so
yeah.
you're opening up, it just peels. Now, the fun part about it is it takes me about 5 minutes to dissect the
Less,
spine on those patients
yes,
because it literally,
yeah.
you make
Less
the incision,
muscle.
you go, and it just
Yeah,
opens up. But
yeah,
as we're putting in our screws and stuff like that, especially if it's somebody like really like severe cases or bigger cases, I'm always mortified. I'm like, man, this is a petri dish. So we do everything. I'm putting in Venco beads in there and
yes,
washing it with
yeah,
betadine and
yes,
doing all this antibiotic stuff and doing all these things. But it's a huge, huge problem. And people do not want to understand their role in taking care and managing themselves. They're abdicating it to the world or whoever's marketing to them or big food and a lot of this is like that's why I wrote this book. And I did a radio show yesterday. I did a 1 hour monologue And we can teach you whatever all this stuff. I mean, I literally I pour my heart into trying to teach people how to live better and do stuff. But if their mentality is broken, if they just want a miracle without doing any of the work, and I quoted this one of my favorite quotes ever, and I heard it on this other show. But anyway, it's the magic you're looking for is in the work you're avoiding. That goes
Yeah,
for
pretty
everything.
much.
They're
Yeah.
looking for magic. And these patients, you're 5'2", 320-pound people. Like I can't miracle that away. Like
Well,
you have to be like you have to, and the line is the CEO of your own health. You got to take it into your own hands because no one's coming. No one's coming
I'm
to
sure
save
I'm
you.
sure you've done some traveling around the world, right?
Of
And you go
course.
to different countries and you just don't see. I mean, I pay attention to this because
Of
like
course.
you, I see 100 patients in a clinic and like 60% of them are obese. And when I go to another country, I'm like, wow, look at this. I don't see obese people.
No,
You
it's
just
totally
don't
different.
see it. So, I mean, I think because we're so industrialized and there are, I mean, I live in California, right? And one of the biggest food chains here in California is In and Out. Okay. And it's probably like the healthiest one, more than like Burger King, McDonald's, and everything else, right? But like when you're traveling by an In and Out, I mean, there are people that are gonna be sitting there for 30 minutes in that line to get that burger. And I'm thinking to myself,
Dopamine. They need that dopamine. They
what are
got that
these
dopamine. They're
people
hooked.
doing? What are they doing? We are the fattest country on the planet. You know what I'm saying? And it's crazy. And it's so easy to just eat right. It's easy. And it's actually cheaper. Like you think about $20 of, whatever,
No.
two burgers, of fries, and a Diet Coke, right? For $20, you go to the grocery store, you could buy, some chicken breast that'll last you for like, a week,
Absolutely.
with some vegetables and some rice and potato, and that's your meal, right? So it's absolutely astonishing to me that people just can't see how that is. But like you said, it's the mindset, right? And everybody's looking for that, the quick fix,
The
right?
miracle. They
We
want
already
they
said,
want to be
I tell them I
miracle.
can replace your knee in 45 minutes, but you're not going to do well. It's a higher risk of infection, higher risk of prosthetic loosening, the pain, DVT, pulmonary embolisms, everything is higher risk, with doing surgeries.
The funny thing is a couple issues. I mean, we can go on. This is, it's funny. I think that the audience will, well, hopefully you guys are enjoying this, but I think the real reason they're enjoying it, because if I was sitting with you in the doctor's lounge, this is the shit we'd be talking about the
This
whole
is
time.
exactly what we'd
Like
be
literally,
talking
we would be
about.
talking, and we would both be like, "You believe this patient?" That, and again, and again, for me, it's the opposite of making fun of. I'm not making fun of people. I want to cry
Oh,
for people. I'm
yes.
like, this is what you're doing, and not to mention our colleagues as well. Listen, because of like, I am so passionate about health and wellness. I have the bug so hard for integrative health that I ended up opening wellness centers, and now I have the integrative health clinic where I do see patients and I take care of all kinds of stuff. But and so I've become a real expert at like things like biohacking and hormone management and peptides, all this stuff. I love this stuff. I just consume it. I've got textbooks all over my house on all these things. I sit around, forget the population, okay? I go in the doctor's lounge and I like talk to some of my colleagues. I know they're not feeling well or they're going through some medical episode, whatever. I start having conversations with them about their lifestyles and I say, "Hey, have you thought about this approach or maybe let's look at like some like peptides for you or some of the things that they might not have heard of or think that are like so taboo. Oh my God, peptides." I'm like, it's okay. GLP-1s are peptides, insulin's a
Yeah,
peptide, oxytocin's
yeah.
a peptide. Let's take it down. Let's calm down for a second. And I'm just telling them about like supplements they should. And I get like, why don't we get you on some taurine and some other stuff? But let's look at some of the stuff maybe to curb. They're like, that doesn't do anything. That won't work. They're so resistant. And
Yeah.
so I think we can extrapolate. Just think about this for a second, because you mentioned the doctors, like you go to your internist, they're 400 pounds and they're telling you about your diet and your diabetes. I'm not making fun of them. I'm like, give me a break. I mean, come on.
Yeah.
But anyway, it's like, if you think about how entrenched, how brainwashed the American mindset is, and not just America, just the Western, it's like the Western world now, because Australia is getting bad and all these countries are getting, as I talk to these doctors too, and they're like, "Oh no, it's just as bad here." if you think about it, if our own colleagues are brainwashed and stopping at In-N-Out Burger, and then I want to do a time lapse. I don't know if you've ever thought about doing this. Have you ever thought about doing the time lapse to like the donut thing, like the thing where they put the donuts and the croissants and everything? Time lapse. I'm like, let's see if we can break a record today. Let's see if it's all gone in 22 minutes. Meanwhile, if they put out fresh fruit, oh, that's there all day.
Yeah, exactly
All
right.
day, no problem.
Yeah.
So I
Well,
always know
this
that's
is
going
the
to be
problem
there.
also is that I don't know. Again, you and I are kind of like the same years in training, and I know it's different now in medical schools, but they don't teach nutrition.
No, zero.
Zero.
I don't
Zero
remember one
nutrition.
second. I always say five
Zero.
hours, but I don't
Yeah.
even. I'm like, I don't
I
remember
mean,
that 5 hours.
let's not even talk about how many orthopedic lectures you got in medical school, like zero, right? Right? Like we are a completely different breed of people, right? If you had no interest in orthopedics as a medical student, right, in medical school, you may get one lecture about this is a bone and
This
this
is
is
a
parts of
ball.
a bone, and that's it, right? You don't have to do any orthopedic rotations, nothing. So like for us, orthopedic, even the doctors that are doctors don't know what we do, right?
That's
They're like,
correct.
or if this, but they don't really know what we're doing, right? But you and I know what a colectomy is. We know what an appendectomy
Of course
is.
we do.
We know how to deliver a baby because these are the things that we had to do as
Yeah,
interns in the beginning because we know we were in their world, but they were never in our world, right? So that's one of the things I preach to my patient. I'm like, listen, you have to work out because we always learn that our skin is our largest organ in the body,
correct. Yep.
right? And it's an important organ, but I think the most important organ is our muscles. Our muscles generate everything in our body, right? It's our engine. And if that engine is just idling all the time and not getting
Right.
driven like it's supposed to, it's just going to wither away. And the only way to put this engine to work is take it on the racetrack. And what I mean by that is resistance exercises. And it's never too late. Even if you are 80 years old, it's
Yep.
never
Preach.
too late to start.
So, two things, and people have heard me talking about this that want to be tortured by listening to all my rants and everything like that. There's two things, longevity, two things. I'm not talking about genetic. People say, oh, but what genes? Forget two things: VO2 max, amount of muscle that you carry. That's it.
That's it.
That's it.
That's it.
That's
Yeah.
it. It's the most simple thing, but no one does it. How many of our patients, I mean, percentage wise, I would say probably 50% of my patients that are over the age of 50, they no longer exercise in any way, shape, or form. And some haven't even seen a gym or exercise or gone for a run or done hills since they were like in their 20s. And
Right.
then we see them, and then they become the Petri dish. And then
Yeah.
they're sick and they have cardiac disease and they have stroke. And you speaking of skin, they always have like skin rashes. They're swollen. They have autoimmune diseases. They have, they have early dementia. All of these things are associated with our lifestyles. And we need to treat, like we really need to teach this, but we also need to teach it to the general population, starting when they're at the grammar school level. And we don't impart this enough because they really need to understand how their choices today are going to affect what they look like, who they are in the future. I do the reverse thing, and I don't know. You two tell me your strategy when I'm trying to get them. And now that like I'm down the integrative health path, it's nice because I see patients there and I spend an hour with them, and we do all these advanced labs and all this stuff. But when I see them at the spine clinic, if I'm really mortified by the person in front of me, and this happens every single clinic. And I just say, look, I say, listen, um, we have to have a frank discussion. I know you want to talk about, your spondylolisthesis. Yes, we can fix that. You have horrible stenosis, but I don't want to talk to you about that today because you're not doing the operation. I've done thousands of these. You could look me up. We could talk about a little bit, but let's talk about your lifestyle and your health and what's going to happen after this. And sometimes the way to shake them out, which I do, is I do the backwards looking mirror. I said, let me take you on let me do the Ghost of Christmas Past on you. And they're like, what are you talking about? I said, let's have a conversation. When you were in eighth grade and you were excited about the world and about life and you wanted to be an astronaut or a firefighter or a doctor or whatever you wanted, an actor, or you wanted to be a speed skater. I don't know what you wanted to be. Is this the person that's sitting in the room right now? Did you ever think that this was going to be you? 46 years old on 17 medications, having had like bypass, and again, I get it. There are some genetic components to this stuff, but if
Sure.
you dial down to it, 90% of it is lifestyle. It's
Yeah.
what you've done with your life and stuff. And when we do that, I can't even tell you how many tears we get. And they're not tears, like they're not mad at me. No one's ever complained about me having these discussions with them because I'm just a dude. I
Yeah.
mean, I just go in there and just
Yeah.
start talking to them about, and I'm doing it because I care.
Yeah.
And they start crying, and we have been able to make some amazing interventions with people. And to be honest with you, that to me brings more satisfaction than them, their leg pain being gone after a surgery. Because I know that's what's going to happen. That's what we
Right.
do with this surgery.
Right. Right.
So
Well, a couple things. So I wanted to, I know we've been talking about our patients and the ones that are complicated with all the, but you and I have been practiced long enough to know that we do have some badass patients, right? Like I
yeah,
have
we
patients that
sure
are like,
do.
right? Like it's the bell curve, right? So most of the people are in the top of,
Yeah,
curve
yeah,
here.
yeah.
They're like the bigger, heavier, not healthy.
Right,
But
right,
we have
right.
some patients that are elite patients, and
Elite.
these
Yes,
are the patients that I offer, like if they come in with bilateral hip disease or bilateral knee, I'll replace both of their hips at the same time. I'll replace both
yes,
knees at the
yes.
same time because I know they're going to do well. And I know they're fit, right? Maybe they've
Yep.
had some sports injuries when they were younger, but they're still working out. And the reason why they want to get their knees or hips replaced is because they can't go on their hiking and they can't go on their
Right.
fishing trips and all that stuff. So we do have patients that really do take good care of themselves, but because of age-related
Of
issues, prior
course, of
injuries,
course,
they need their backs,
of course.
surgerized or their knees. But most of the, I'd say, 80% of the patients are the ones that we were talking about earlier, the ones that are not healthy, continue to smoke, continue to drink, continue to eat like crap. And then now they come in because, they need, they're having pain for whatever reason. And we're trying to, modify their lifestyle, but when they've doing it for so long, it's hard. I understand it's hard, but like you said, it's something has
It's
a
a
flip has to
it's
switch
minds.
or
It's
switch
just
has to
it's
flip. Yeah,
Yeah, it's a mindset, just all these different ways to try to break through to people. Because as you know, we all come from different backgrounds. That people come from, like, it's crazy stuff. Talk about a fly on the wall. If people could be a fly on the wall in our clinics, some of the stuff that comes through, people's just like bizarre, the most bizarre stories, or
yes,
saying like the most bizarre things to us. I love it.
yeah,
I actually, people are like, oh, spine clinic, it must suck. I was like, no, I just,
yeah.
I get so much energy from my patients and listening to their stories, but really just ultimately wanting to help them. But I'm always thinking, like, as they're talking, if they're not well or obese or diabetic, all the stuff, I'm just thinking, how do I break into this patient? Like what trick can I use to like trick their brainwashed mind to think about? And then the other one is going the future. I just like, listen, I'm going to tell you right now, you are at a crossroads. You are 50 years old. I love to use the word 50 because I feel like 50 is a slippery path for people.
Yeah, yeah,
40 to 50, even if you're really bad, it's easier to reverse stuff. Once you get into your 50s, there's a point where yes, you can get better, but you can't get back to like an elite. Some people, it's just you're so sick. You've had like so many procedures. But anyway, I try to do the forward-looking thing, like the ghost, I say, like ghost of Christmas, future. It's like, okay, if we look at today as day zero, right? Day one, right? One day or day one, the rock thing, right? And say, where are you going to be in 10 years if you do this versus where are you going to be in 10 years if you continue down the path? I was like, I know where you're going to be in 10 years. You might not be here. So
right.
that's step one, heart attack, stroke, obesity. You're going to have like peripheral edema. We go on and forget the joints,
Yeah,
right? Hips, knees, right? For every pound, yeah, every pound, it's 4 pounds of extra pressure on the knee. We
correct.
go on
Yeah,
forever. Your spine's going to be a mess. You're going to be in a state of inflammation. Your brain's going to be a mess. You might have early dementia. You might be 58 years old and not know where the hell you are
yeah,
because of that you're turning on genes you don't want to turn on, right? And so it's just breaking through to these patients, before we, like this has been fantastic, but we cannot not talk about like our own personal routines. And we
right.
don't have, and you said it right. You don't have to be a shit. And I've never been, I don't care. I just tell people I work out almost every single day and I do all these things. So what I'd love to know, because again, you do these like shirtless. I mean, you had a great post that I watched. It's awesome. I'm like that dude. I mean, is he an orthopedic surgeon or is he a personal trainer? It's hard to know. You could have just been talking about personal training. You didn't even have to say a word about ortho. And people say, "Yeah, I'm going to hire him. He looks great. I'm going to hire him as my personal trainer." What's your own personal routine? Are you like 5 days a week, 7 days a week? Do you do any biohacking? Are you doing any peptides? Like what else do you do? Like what are your secrets to looking the way you
Sure.
do at
Sure. So,
55?
so I'm 55 years old. I would say, I mean, I've been, kind of working out almost my whole life, but it's been like this. And when I started practice 20 years ago, when I look at the pictures of where I was 20 years ago, I think I'm in much better shape today than I am back then. And when you look at me 20 years ago, I was probably about 220 pounds, 215 pounds. I'm 6 foot tall, right? Today, I'm 6 foot tall and I weigh 185
It's
pounds.
amazing.
So in the last year or so, I really took life by the balls. And I said, this is it. And what sparked that for me is my wife is a nurse. And we're sitting on the couch and we have a home blood pressure monitor. And I'm sitting on the couch and she's taking my blood pressure. It was like 150 over a 90 or something like that. And I know that's hypertension, right? And I was weighing about 220 pounds a year ago. So in the last year, I have just completely turned everything around. And I know what to do. I don't need a trainer to tell me what I already know, right? We already know what to do, right? You don't need a trainer. The only reason you need a trainer is to have some accountability, right? Like, that's what you're paying them for. You're paying
Correct.
them for you to show up,
Yes,
right?
sir.
You can figure things out. You can go to the gym and it doesn't matter what you do. Everybody, you see all these people on social media, all these trainers and
Yeah.
everything else. So do this, do that. It doesn't matter what you do. Just do something. Doesn't matter. Consistency. Do something. I don't care what it is. Go lift up a rock every day. Just do
It's
something,
actually a
right?
good workout.
Yeah. So what I do is again, you are busy, I am busy, but working out is always in my brain, right? So there are days where I wake up at 6 o'clock in the morning to get to surgery by 7:30, and I'm operating all day, or I'm in clinic all day, or clinic and I have surgery all day, and I don't get home till midnight. Do you think I work out in those days? Yes. You know what I do? Do you know what I do? I
No,
go in between cases. I'll go in the freaking doctor's lounge and I'll do 30 push-ups. And
that's
then after the next case, I'll do another 30 push-ups. And I'll do an L sit at the chair and hold my legs out to work my abs. That's how intentional. You have to be
intention.
intentional with
I
what you
love it.
do. Intentional. No excuses. No excuses. But on the days that like a day like today, we'll have, just a couple surgeries. I'll have, an hour workout. That's it, an hour. And what do? I typically do like a full body workout. I like to work out everything.
Mm.
I'll do dips, I'll do shoulders, I'll do tries, I'll do
Mm.
legs, kind of get everything kind of working, right? To again, take that car around the racetrack and burn some fuel, right? And then the diet. We are what we eat. Literally, we are what we eat. And I know that, I know like the whole food pyramid now has changed, right? Now, before it was like, protein up here and
Yep.
carbohydrates down
Yep.
here. Now it's inverse, right? Now it's all about the protein. It's all about the complex carbs. I basically eat fruits, vegetables,
Yep.
and meat. That's pretty much it. I try to stay away from breads. Do I have a piece of bread here and there? Yes. But 90% of the time, no simple carbs, no pasta, no bread, no potato chips, no cookies, no cakes, none of that garbage, right? Now, in regards to supplements, what do? I'm on creatine, which is probably the number one most studied.
How much do you take? I mean, I recently, like, if you look at the literature for creatine and brain
Yeah,
health,
yeah,
it
20,
that have
20
come out in the
milligrams,
last
that's
two,
what they
it's
say.
crazy. How much?
20 milligrams. So I take it
Oh,
in
so
two.
yeah,
I take it in two forms. I take 2 scoops or 3 scoops in my coffee in the morning because it's tasteless, right? You don't
right.
taste it.
Yeah.
So that's about 15 grams. And then I also do, because I like gummies, so I take another 5 grams of
Love it.
creatine gummies.
Phenomenal for brain health. It's
Yes.
amazing for
So I
because
do
once
the
you saturate
creatine.
the muscles, you get all this, crosses the blood-brain barrier. It's amazing for that. But keep
Yeah.
going.
I do collagen in my coffee also,
Yep.
which is basically not, it has no taste to it, right? One of the things, and one of the posts that I did, I don't know about, a few months ago, which is the day in the life of the orthopedic
Yeah.
surgeon, and I got inundated with questions about methylene blue. So I do methylene blue, right? And I think it helps. Sometimes my wife makes fun of me because you're on so much shit, you don't know what's doing what. But I feel good,
You
so
know, I
sometimes.
got I got to stop you for 1 second. It's so funny. My kids, one's in college and one's here, but they both make fun of me with the methylene blue stuff.
Yeah.
Now, first of all, methylene blue, folks, because that's like a hot button topic, right? Because that's an
Yes.
RFK thing, right? He's always with
Yes.
his thing on the plane. And RFK, I mean, right now we're so polarized. Listen, I'm at polarization central here
Yeah.
in Minnesota.
Yes.
It's
Yes. Yes.
crazy. But anyway, the methylene, my kids make fun of me again. I was just explaining to them the electron transport chain and mitochondria and how it can skip a step and you get stuff. And I think it works. I don't do it all the time, but I do some. But it's funny. I did do a post on methylene blue a while back, and I got the most questions on that like anything that because people are just so interested in
Yes.
something like that. And I just say, you know what? It, just you be careful with anything you do, but
Yes.
methylene blue's been around for a very, very long time. And people have used it for many different things. And it's just, we are open minded. And as orthopedic surgeons, we tend to be the most open minded of everyone because, again, we're kind of like over there. They put us
That's
over there. Oh, you guys are the mechanics. So do that. So we think differently. But go ahead. What
but
say you?
but but I will say this, whether it's a supplement, whether it's a medication,
Yeah.
whether it's working out, nothing that you do in one day will show you any results, right? If you go to the gym and
Right.
it's your first day and you're doing buys, you're not going to see anything the next day, right? It's all about consistency and persistency. And it's the same thing with creatine. It's the same
Right.
thing with methylene blue. It's the same thing with the collagen. You have to be consistently on this stuff, right? And eventually you look at yourself from day one, take a picture in front of yourself naked in front of a mirror, and do the same thing in
Right.
3 months. I guarantee you will see a change. 100%. You will see
Intention.
a change in your physique,
Yeah.
right? Not just in your
Intentional.
physique, but in your overall brain, your overall
Correct.
thinking, your overall everything, your life. When you are dedicating yourself, we all wake up and we all go to work. Why? Because we have to. We have to. We have to wake up and go to work because we have to pay our bills and we have to take care of our family, right? But we don't have to wake up and work out every day. There's
Correct.
no gun to our head. That's something that you choose to do to better you, to better me, right? And if I'm better, then my kids are better, my wife is better, my life is better, everything is better. But the thing is, people don't see that, right? It's hard to do. It's hard to. I was operating yesterday at the hospital, and there was a gentleman who was a rep. He was doing some stuff with a new Bobby that we have, the suction Bobby, and he's like, Doc, he's like, how do you stay so fit? I go, did you have anything to eat today? And he's like, yeah, I had breakfast and lunch. I'm like, I haven't had anything. I go, sometimes I do like an OMAD. I'll go one meal a day. And I feel like when I don't eat, and that's another thing I do, is I'm not starving myself. I think starving yourself is, being in the desert, not eating for 3 weeks, right?
Correct.
This is a self discipline
Yes.
that I've taught myself to not, I don't need to eat, and my body is doing just fine, right?
Intermittent fasting.
Intermittent fasting.
It is absolutely my lifestyle.
But
So I
intermittent fasting is a little different than OMAD, right?
yeah, a bit different.
Intermittent fasting is you get to eat for, 6 hour
Window,
period
windows. So yeah.
windows, right? I'm only eating, sometimes I'll only eat one meal a day. So I'll have my coffee in the morning, water, maybe I'll
Yeah.
do like a, electrolyte drink or something. But my main meal is at, when I come home,
Which
you
is
know?
amazing. I mean, it's amazing for your body because you're taking out the trash from your cells and you're
Yeah.
clearing your brain. That's why I like intermittent fasting. I mean, I usually do 6 to 8 hour windows. I do that, but I work out a lot. I'm in the gym a lot, and so I've gone now to doing 5 days of the intermittent fasting and then 2 days of just pigging out and doing the refeed because my body responds better to that. Because as you know, like we use our own bodies as an experimental testing ground. Same thing with all the
Yes.
supplements. I'm just going to test
Yep.
it on myself,
Yes.
and
Yes.
and see how it works. Do you do any biohacking stuff?
In all
Literally.
transparency, about 5 years ago when I turned 50, I noticed that things were a little different with me,
Yep.
energy level, libido,
Of
uh,
course.
sleep, everything else. So I got tested, and now the big thing is TRT. So I'm on
Yeah.
testosterone, and I take I inject myself 1 cc of testosterone cypionate per week, you know? So like when I see these, you know, people on social media, oh, you know, even commenting about me, oh, he must be on steroids. Yeah, I am on steroids, but I'm not on steroids to be like Arnold
You're
Schwarzenegger
on steroids to be at a normal level,
at a normal level. Because when I tested myself, you know, it was around 250, which is
which is
kind of like
super.
low normal,
That's
right?
not low normal. That's extremely low. Low
Yes. So
normal for
now I'm
the,
hovering
yeah,
around 750, 800,
perfect.
stuff like that,
Yeah,
which is perfect. And I feel great,
perfect.
right?
Perfect.
So, yeah, and it's the same thing with women. I'm so glad that they
Yeah.
removed the black box from estrogen for women,
100.
right?
Yeah.
Because
Huge.
estrogen is a huge, I mean, it does so much for women. It does, you know, the cardiovascular, the bones, the brain. I mean, it's just a
I mean, it
huge.
makes them women, for God's sake. Let them,
Yes,
their
yes. And
estrogen. It's the dumbest
my
thing.
wife is going through that right now. She's 46 years
Yeah.
old and she's going through perimenopause. And literally, you know, a few weeks ago, she just had like the pellets injected in her because she was so low on estrogen.
Yeah.
She didn't know what was wrong with her. And now she's like 3 weeks later, she's like a new woman.
That's
It's
amazing.
unbelievable. Unbelievable. You know, there's so many different things that you can do for yourself. But you know, everybody's like you made that statement, biohacking, right? I mean, it's
Hacking
simple
your
stuff.
biology. I mean, having a good diet is biohacking.
Yes,
Doing OMAD is biohacking.
yes.
When I say biohacking, I mean like, there's the hormonal stuff which you brought up. I am a huge proponent of these photobiomodulation therapy. The light therapies are a game changer. So we're treating in our integrative health clinic. Again, I never thought I was going to go down this path, but I can't even tell you how many people we have that have bad autoimmune disease that have had dramatic improvements with these light therapies. We treat concussions with laser therapy to the brain and green light therapy for their headaches because it releases the body's own natural opioids. We do oxygen therapy, which is one of the best longevity hacks people can do. So I do exercise while under oxygen therapy.
Are any of these modalities that you do in your clinic, in these clinics that you have, are any of these modalities covered by insurance or it's all cash pay?
No, so we do it as a big package. So it's all cash pay. Although I will tell you, you know who is paying for them? Workers' comp. They love us because we save them so much money on these injured patients because we do a lot of class 4 laser therapy, which there is a code. You could bill like you could bill Medicaid for it. It's just not going to get paid anything for it. But
So
they're
I'm gonna play devil's advocate here,
shoot.
okay? And I'm gonna ask you, simple question. If these people are still doing so great, and not that I don't believe in it, right? Because I'm sure
Yeah,
it
yeah,
works.
yeah, shoot. No,
But
no, this is good.
if these people are doing so well with all this biohacking,
Yeah.
why are you still using a knife?
Oh, that's a good. I mean, because there's structural problems. So that is a great question. So I'm going to take a little. I'll tell you my thing on this. I just did a post about, being 10,000 surgeries, what I learned from doing 10,000 surgeries, and one of them, number four, my point was that I learned with these other tools that most people do not need to have spine surgery. Okay, I'm not trying to take away business from my own team or my spine surgeons or whatever, but most people. So I would say this. I think that true structural problems, so I differentiate it is like when we look at spine, which is different than other things. When we look at the spine, there are things that structurally you could biohack all you want. You could replace your testosterone. I could put you on pep. It ain't
A
going to do
herniated
it.
disc is a herniated disc. It's
No,
pinched
hernia,
nerve and you're
right.
excruciating pain.
Severe spondy with a 3 millimeter spinal canal, and you can't walk a half a block. We're not biohacking anything. That is a structural fix. You
You're
have a
getting the
car
knife.
accident. I'm
Yeah.
not like, hey, ma'am, you know what? We're not going to operate on you. We're just going to do some red light therapy and call it a day. But I will tell you this, for the average pain, and again, I'm doing this across the board. I enter integrative health. We treat every disease. Like you just name a disease, we have a patient in there.
Sure.
But when it comes to spine, those gap patients, which are the patients where they have pathology. I'm sure you have stuff in your back. I got plenty of stuff in my. You should see my L5S1. I'll show if I
Same
sent you
one. Same
my
thing. I had a
L5S1
herniated
is
disc at 35. I was limping for a year.
my L5S1 is gone. But I
Same
have
thing.
no
Same
pain,
one.
but I do
And I
do
have no
laser
pain.
therapy.
Zero
I,
pain.
I have no pain. But
Yeah.
regardless of that, if for those gap patients where either their symptoms don't justify surgery or their structural problem is something where people have been doing a lot of surgery on, but if we could make that go away, it doesn't matter because their spines look like everyone else's spines, in the world, right? And
Yes.
so those people, those gap patients, I'm not talking about the scolies and the advanced stuff we do. I'm talking about like people that have like degenerative disease or facet arthritis or same thing in their neck, or they have whiplash syndrome, whatever. They end up having all these big surgeries, and we literally legitimately can treat them with a combination of laser therapy and other photobiomodulation and oxygen therapy. And I put them on, regenerative peptides, some of which have good data, some of which have minimal data, but anecdotally, they're amazing. Some of these things, I'm just frank with the patients on what we know and what we don't know. We do all these things to reduce their inflammation, boost their mitochondrial health, and it really is a huge, huge difference in ortho. And I will tell you because now I actually have a guy on my podcast next week, this Mark Pederoli. He's up in upstate New York. I've been following him. He's really good stuff. Laser therapy. Listen, if you can't walk anymore and you need surgery. And
Yeah.
and the surgery, and people do amazing with surgery, so they should have surgery.
Yes.
However, there's the in-between patients where they have, some chondromalacia, or they have, not that much pain and they're getting along, or they're younger. These regenerative medicine options, I mean, I know you guys do like stem cell
Yeah, yeah,
stuff.
I do all that stuff. I do plasma, I do exosomes,
Yeah, you're doing.
I do a stem cell, and here's the thing about, the whole stem cell thing, right? There's a lot of non-surgeons out there, whether they're
Correct.
like pain management
Yep,
doctors
yep.
or different type of doctors that will offer people stem cells. And I tell my patients, just beware of what you're getting, right? Because it's very easy to buy something that's in a bottle, right?
Right.
For the doctor to inject you into your hip or your knee or your ankle or your shoulder, whatever it is. But we don't know what's in that bottle, right? We don't know if it's alive, not alive. Was it
Or the
initially
plant-based exosomes, stuff like
yeah,
that.
yeah,
All that
well,
stuff that's out there.
even the stem cells, right? They say it's embryonic, but it was dehydrated. Then you have to mix it with water.
Yep,
There's
yep,
nothing
yep,
that's
yep, yep.
alive in that concoction. So I only do one type of stem cell, and I don't know if you want to call it stem cells, but I get it from your iliac crest
Yeah,
bone marrow.
BMAC.
I
You do
get
BMAC. You
bone
do
marrow
BMAC.
aspirate,
Yeah,
right?
BMAC.
Human.
Yeah.
So I get it autologous. It's your old stuff. I don't need to worry about whether it's alive or not. But I will say this: I've been doing it for the last 12 years, and there, like you said, there are patients that are what I call tweeners,
The
right?
tweeners, the gap
Right.
patients. Yeah.
They're not ready. They're in their 30s, 40s. They're not ready
Yep.
for a knee replacement, right? They're not ready for a hip replacement. Yeah, they have some chondromalacia in their joint. They got some arthritis in there, but they're not ready for that joint replacement. And then even people that are bone on bone, right?
Right.
People who are like they have no cartilage left. They're basically ready for surgery, but they're not ready to get that surgery yet. Is there anything else you can offer me? I tell them, like, listen, we can try some of this plasma, we can try some of this bone marrow aspirate. It will help, but it's not going to prevent you from getting that knee replacement. It'll just buy you a little bit more time. And I don't think there's a lot of honesty out there with doctors who are doing this type of medicine because it is a cash business,
Yeah.
right? It's a cash business. Unfortunately, the insurance companies are not paying for the plasma. They're not paying for bone marrow.
Right.
They're not paying for stem cells. So for us, it's a cash business. But I'm very mindful, for the patient, especially with the population that I work with. They're not from Beverly Hills, right? They don't have umpteen dollars to spend. And these things are costly because we have to do them at the surgery center, blah blah blah, and the equipment that we have to use. So I'm very mindful with that. And I don't want to just blow smoke up there, you know what. So, if I tell them like, listen, don't waste your money. We're going to be doing, like you said, we're going to
We're gonna
decompress that
fix. Yeah, we're
spine,
gonna
or
fix
we're
your
going to fix
structure.
it,
Yeah.
right? But if it's somebody in their 40s, 50s that, they have some
Right.
grade 3 or 4, they're not bone on bone yet. Of course, we're going to offer them these things.
Yeah, I think that what I would say is that you're absolutely right, and it is a pet peeve, and we're trying to get this information out because we do some. So Dr. Sager, who is a pain management guy, but he was part of our clinic for years and years. Then we went off on his own, and now we got back together and did a stem cell center as part of our integrative, like as part of my integrative health, deal. There is in Minnesota that there are so many people that are doing like these watered down like stem cell like it's nonsense and it's not going to do anything, and they do tell patients they're going to have, it's a miracle and this and that.
Blowing
the,
smoke,
the
blowing
difference
smoke.
is the one thing that Dr. Sager does, which I'd be curious to hear like your thoughts on it. he does a procedure, and he's the only one in the state. Nobody's doing it. He does intraosseous subchondral stem cell injections, like for knees. And if you look, there's a guy, his name, and I'll send you the article if you're not familiar. There's a guy, he's a French orthopedic surgeon. His name is Dr. Hernigou. And he published these two things. I actually wrote a white paper. It's on our thing. I'll send it to you. And he looked at, and it's absolutely right. If you take BMAC, if you do BMAC, you do it intraarticular, people do well. I mean, they improve, they do well, but
I've seen it happen.
it's a bit, no, they do well. They
You
do
do the
well.
cortisone, you do the plasma, then you
Yeah,
do the
they
beam.
do.
It's just that you see the patients, they come in, they're like, oh my gosh, I feel so much better.
No, they're good. No, they do good. And obviously that's why you're offering it, right? Otherwise
Yes.
you wouldn't even offer that. However, the advantage, and so we're very frank. So people ask us, they say, yeah, then that is like the cheaper version. You're right, if you're not going to do it. But Dr. Sager actually does intra-articular subchondral injections like throughout the knee, like depending on if it's lateral, medial, or both. And if you look at Hernigou's studies, it's actually fascinating. So he took the same patients who needed bilateral total knee replacements, and on one side he replaced their knee. He's an orthopedic spine surgeon. I mean, orthopedic knee replacement surgeon. So he did one side knee replacement, the other side intraosseous stem cell injections. Very different. And he compared the two. At 15 years, only 20% of the patients need to convert to a total knee replacement. Now, these are much, much more like, advanced procedures. They're more pricey. They're that you need like to be a real expert. Obviously, if you're doing intraosseous injection, you need to know how to target from a 3D standpoint and do all this stuff. But the results are better. He also compared intra-articular versus intraosseous. Now, intraosseous procedures, that's like not a small deal. Like you're getting a giant needle smashed into your bone, and it hurts more, and there's more recovery. But the longer term outcomes are much better. Yeah, you got to look at it. It's fascinating. I read that. I was like, this is amazing. So I didn't know any about it. Dr. Sager taught me about these things. So we offer some of that, but just being like totally upfront with the patients, especially when it's a cash, is very important. And some of them come because they've gone to other clinics to do their stem cell stuff. And then we look at what they've done, and I'm like,
yeah, exactly
you
right.
paid $10,000 to have like something that's going to wash out of there. And like, it's like even the spine stuff.
We're very close to Mexico, right? So we have some patients that will drive down to Tijuana to get some God knows what they get over there. I have no idea what they're getting because it's a little cheaper. And you don't know what you're getting when you go into these,
You got to be really, really careful. I had a group from them on my podcast, the Dream Clinic. They're on the up and up. I researched, otherwise I wouldn't bring them. I'm not going to bring them on my podcast. But the most fascinating stem cell discussion I had with abroad is with a guy that founded the Panama Stem Cell Clinic. And I went out and I had him on my program, and we were just talking about like these placental stem cells, like these day zero cells, and all this stuff they're doing with spinal cord injury. The difference with them, his name is Neil Riordan, by the way. He has like probably the most famous stem cell textbook out there. Actually, like it's not a textbook; it's a fairly small book. I read it. I called him, and the next thing you know, we were speaking for 3 hours. Like the day I called, he got right back to me. I was like, we just had this conversation. But anyway, I went out, did the podcast with them. They have the craziest process at their facility to grow all these very specific, like genetically modified lines of stem cells. It's actually really interesting. And he got famous, his clinic got famous because Mel Gibson took his dad out there. It was one of the things. So Mel Gibson took his dad out there, who was at Mayo Clinic. They took him to this stem cell thing. And it was a hip problem, but a systemic problem. And he got like literally cured. And he was 92. He lived to 102. So Joe Rogan had this guy and Mel Gibson together on his podcast. It's a really cool show. So it was cool that I got to have him on my show, and we did it live, and it was fun. But I think there's a lot of future of stem cells. But I think that any ortho guys or spine guys listening to this, you don't have to worry. There's so many people to operate on, guys.
Yes.
That it is like with the baby boomers now, it is an endless pipeline of people that need spine surgery and shoulder replacements and hip replacement. It's endless. And so, yes, regenerative medicine is probably going to replace a small portion of that.
Yes.
peptides, new molecules that are coming out because of AI research and things like that. But I think that we've got job security for quite a
I
long
mean, if
time in
nothing
what we're
else,
doing.
it'll buy you some time. We
Correct.
literally had a dinner last night with another hire that, kind of introductory dinner with this new candidate that we're going to hire. And I was telling him, like, listen, there's 6, 7 orthopedic surgeons in our group, and none of us are competing against each other. Like, if you're busy tomorrow, I'm happy for you.
Great.
So many patients that require surgery that we don't need to compete against each other. Everybody's going to be just fine.
We say the same thing. It's like people are like, "Oh, your competitors are doing this and that on the website." I'm like, we are inundated with patients. Or like, I don't care. Like we're at the point, and I know you guys don't have that. I mean, you have distant competitors, but not in your area.
Yes,
But
right.
even if they came in your area, there's so much to spine. Like we got 95-year-olds coming in wanting their spine fixed, and I said, whoa. Let's
Slow your
let's
roll, slow
just
your
like
roll.
let's breathe. Let's talk about like life. Let's talk about your life. Let's talk about your life experience.
Yeah,
Teach me about life. Like what do I need to do to make it to
yeah,
95? I just changed the
yeah,
subject altogether. But
yeah,
anyway,
yeah,
there's an endless amount of people that really either need to be fixed or want to be. Some people in spine, as you know, some people want to be fixed, but the only thing that's going to fix them is lifestyle and maybe doing some biohacking, doing all this other stuff.
yeah,
I'm like, you got 3 bad discs. Like, I'm not. What are we like? You want a 3-level fusion
yeah,
or like 3-level disc replacement? How about you change your lifestyle for a year and then maybe we can consider something.
yeah.
Maybe. This has been great. I mean, honestly, this is we could go on for days
Hours.
on this.
Yeah,
Literally, we could go on for days, and we're going to pick this up. I'd love to do one with you live, so I'm just announcing it right here. So, listen, this has been great. We share so many things. I mean, it's crazy. I didn't know any of this stuff. I mean, I knew your resume, like all the like the normal stuff. I didn't know we were both at Tampa. Like obviously we're both bald. We have a easy, time of it to get ready, for work. We both have very similar stories as far as building, practices in the private, practice world, which is a whole other, we could do entire podcasts on how to survive in private practice and what people need to do. We both love to be in the gym. We both love to do some form of, fasting. We both love to preach to our patients that they've got to take, like matters into their own hands. And
yeah,
so, I mean, this has been wild and just kind of we're just, lockstep and not every, I mean, there's a lot of orthopedic surgeons that might not, agree with, some of the stuff we say and our stuff is whatever. But for the most part, I feel like ortho guys just see the world a little bit. It's a little bit different. We're just kind of our own, in our own world. And I'm trying to pass this on to all my neurosurgical colleagues
yeah.
they're a different breed. Like
Yes.
they're
Yeah,
different. I have the
they are.
coolest neurosurgeons, by the way, so don't get mad, guys. They really are. We have the most normal neurosurgeons in our practice that you could imagine. Because when you think neurosurgeons, you're like, oh my God, that must be fun with 6 neurosurgeons over there. No, they're really good guys. But anyway, this has been fantastic. So how can people like where people are going to, I mean, after watching this, how could they not want to, reach out to you and see what, what's going on? How do they reach out? What's the best way? Do you want like, tell us where they can reach you, what your handle is and all the good
Sure,
stuff.
sure. My office is located. I have 2 offices in Southern California. One is in Lancaster. The other one is in Mission Hills in Silmar. So my office number is 661-726-5005. If you need to schedule an appointment to see me, if you want to follow me on social media, it's Antebi Ortho, Antebi Ortho, TikTok, Instagram, Facebook.
And he's a star on those. I mean, seriously, like you got some good stuff. Like I said, I'm good. I was like, I got to do some of this other stuff. I told you, I'll wait for the working out thing until we do it together. We'll we'll
All right.
we'll do
When
it
you come to
together. I'm not.
Cali,
I'm not. I
you
don't
come
know
to
if I'm
Cali,
ready for
we'll
the.
go
I
to the
don't know
gym
if I'm ready
together.
for the
You come to
shirtless
Cali, we'll go to my
workouts.
gym and show it off.
That would be amazing, amazing. So I'm going to take you up on that. I'm going to see if we can
Yeah,
work that in our trip because we're right there. You're right up the road from
yeah,
where we are. So
100%.
guys, look out for that. Look out for our joint orthopedic you combined workout. We'll see what we can do. We're not going to get injured. It's not going to be a big
No,
contest.
no.
It's going to be a nice, fun,
All in fun, all in fun.
all in fun. So we'll see you guys on the next episode of Wellness at the Speed of Light. I hope you hung out until the end. Dr. Antebi, it's been an absolute pleasure. This is great. I look forward to doing this in person and doing it over a fun workout.
Yeah. Thanks for having me.